Welcome to the deep dive. You asked for it, and we definitely listened. Today, we're doing a really focused session on Klinefelter syndrome.
That's right.
Think of this as your key audio guide. We want to give you a solid framework. Maybe you're prepping for the MSRA, or maybe you're just curious.
Yep. We've got a stack of revision notes here. Pretty comprehensive stuff.
And our mission basically is to pull out the absolute need-to-know information, make it stick, maybe even give you a few memory tricks along the way.
Exactly. We'll structure it, make it clear, focus on what's crucial about this specific genetic condition in males. You should feel pretty confident by the end.
Okay, perfect. Let's jump right in then. Klinefelter syndrome. Just starting with the basics, what actually is it?
So fundamentally, Klinefelter syndrome is a genetic disorder, and it affects males. The absolute key feature is they have an extra X chromosome.
Okay, so instead of XY.
Exactly. Instead of the typical 46 XY karyotype, they have 47,000 XXY. And that extra X, well, it causes quite a few downstream effects, hormonal imbalances, issues with testicular function, that sort of thing.
Right. And how does that extra X even get there? Is it something passed down, like through families?
That's a great question. Usually, no. It's typically a random error, a sort of glitch that happens when the reproductive cells, the sperm or the egg, are forming.
Ah, so like during meiosis?
Precisely. It's a nondisjunction event. So an extra X chromosome just ends up in the mix by chance. That means it's not usually something parents pass on genetically.
Okay, so it's a spontaneous thing. Now, you mentioned hormonal issues and testicular function, but the notes I have here suggest it's linked to a lot more than just that.
Oh, absolutely. That's a really critical point. The impact of that extra X is much broader. We see connections to various endocrine diseases, things like diabetes, hypothyroidism.
Okay.
There's also a higher risk of osteoporosis, thinning bones, which can lead to things like vertebral collapse.
Right.
And autoimmune conditions seem more common too, lupus, rheumatoid arthritis. Also, an elevated risk for certain tumors like germ cell tumors. And importantly, male breast cancer.
Well, breast cancer.
Yes, especially in individuals who have what's called mosaicism, where only some of their cells have the XXY pattern. Cardiovascular risks are generally increased too.
Wow.
And there's more. Potential for blood disorders like leukemia or lymphoma, venous problems like DVT, pulmonary embolism, even things like mitral valve prolapse seem a bit more frequent.
God, it keeps going.
It does. Chronic bronchitis, potential for speech delay in childhood,
Sure.
a range of psychiatric disorders, and even an association with autistic spectrum disorder. It's quite a list.
That's a huge range. It really shows how one small genetic change can ripple outwards.
It really does.
Yeah.
And look, to help you remember all that, maybe think of it this way. Extra X can often mean extra associations.
Ah, I like that. Extra X, extra associations. That helps package it up a bit.
It's just a little hook to remind you it's not just about the testes.
Okay. So are there things that make this random error more likely? Any specific risk factors we should know?
The main one that's consistently identified is advanced maternal age at the time of conception.
Okay. Older mothers.
Yes, but, and this is really important to stress, Klinefelters can absolutely occur in pregnancies at any maternal age. The risk increases statistically, but it's not limited to older mothers.
Got it. So it's a factor, but not the whole story. Okay, so we have this extra X chromosome. What's it actually doing on a biological level? What's the pathophysiology?
Right, so the core mechanism is that this extra X chromosome interferes with the normal development of the testes, right, from early stages.
It disrupts things.
Exactly. And this disruption directly impacts hormone production. Specifically, it leads to reduced production of testosterone.
The main male hormone.
Correct. And because testosterone is crucial for so many things, including sperm production, this impairment often results in reduced sperm count, or sometimes no sperm at all, leading to infertility for many.
It's like that factory analogy we talked about before. Maybe having the wrong blueprint messes up the production line.
That's a perfect way to think about it. The testes need that precise XY balance to work optimally. Adding an extra X blueprint throws off the whole system for making testosterone and sperm efficiently.
Okay, that makes sense. Now, if someone comes in and they have some features that might suggest Klinefelters, what else could be going on? What are the differential diagnoses?
Yeah, good question. You always have to consider other possibilities. Other chromosomal disorders could present with some overlap, particularly those involving sex chromosomes.
Right.
Then there's primary testicular failure, where the testes aren't working correctly, but for a different reason, maybe damage, infection, something else entirely, not the XXY karyotype.
Okay.
And you'd also think about androgen insensitivity syndrome. That's where the body produces androgens, like testosterone, but can't respond to them properly. So you get some similar physical signs.
So how do you nail the diagnosis then?
Ultimately, you need genetic testing. Karyotyping is the gold standard.
Mm.
It visually confirms the presence of that extra X chromosome, the 47,000 XXY pattern. Clinical signs point you in the right direction, but the karyotype is definitive.
Gotcha. Karyotype is key. So how common is this condition overall? What are the numbers like?
It's actually surprisingly common. Estimates suggest it affects somewhere between 1 in 600 to 1 in 1,000 male births.
Wow, 1 in 600. That's really quite prevalent.
It is. It makes it one of the most common chromosomal disorders in males.
Mm.
Way more common than many people realize. Often underdiagnosed, too.
Okay, so let's talk about how it actually looks, the clinical presentation. You mentioned it can vary.
Hugely variable. That's a really important point. But there are common features you look out for. Often individuals are taller than average, particularly longer legs relative to their torso.
Taller. Okay.
They might have less development of typical male secondary sexual characteristics, so maybe reduced facial hair, less pubic hair.
Right.
And a key physical finding, if you examine them, is small, firm tests. That's quite characteristic. Infertility, as we mentioned, is a major reason why adults might seek medical attention.
And gynecomastia, the breast tissue.
Yes, gynecomastia is common. Development of breast tissue. And as we touched on, that does carry that slightly increased risk for male breast cancer later on.
Okay, and the hormone levels.
Yes. Typically, blood tests show elevated gonadotropins, that's LH, luteinizing hormone, and FSH, follicle-stimulating hormone. They're high because the pituitary gland is trying to stimulate the underperforming testes. But the testosterone level itself is usually low or maybe low normal.
High LH, FSH, low testosterone.
Got it. Does it look different in kids versus adults?
It can, yes. In childhood, the signs might be more subtle, maybe delayed speech, some learning difficulties. Sometimes they have a noticeable rapid growth spurt in mid-childhood. Truncal obesity carrying extra weight around the middle can also be seen sometimes.
Okay. And then in adults?
In adults, it often presents with symptoms of hypogonadism, low testosterone. So things like low energy, reduced libido, maybe some mood changes. Subfertility or outright infertility is often the main presenting complaint. Or perhaps a failure to go through puberty in the typical way.
So that classic picture you sometimes hear about? Yeah, the sort of textbook description is often infertility, small firm tests, maybe gynecomastia, decreased body hair, low libido, tall stature with long legs and relatively narrow shoulders, maybe tiredness, reduced muscle power, that truncal obesity again.
But it's not always like that.
Definitely not. And here's an important nuance. Sperm can actually be found in testicular tissue in over 50% of men with Klinefelters, especially using modern retrieval techniques. And those with mosaicism, the XY-XXY mix, can sometimes father children naturally. So the idea of absolute infertility isn't always true.
That's a really important clarification. Makes the picture less black and white. So given this variability, what are the absolute key investigations you need?
Well, as we said, the number one definitive test is the karyotype. Blood test, chromosome analysis, that confirms the 47,000 XXY.
Well, gold standard.
Absolutely. Then you'll do the hormone blood test, checking testosterone, usually low or low normal. And LH and FSH, both typically elevated, often with FSH higher than LH. It's also possible to pick it up before birth, prenatally, using tests like amniocentesis or chorionic villus sampling, though that's often found incidentally when testing for other things.
And what usually triggers doing a karyotype in an adult male?
The most common reasons are investigations for hypogonadism, so symptoms of low testosterone, or investigations for infertility. Those are the big two.
Right. Makes sense. Okay, so once you have the diagnosis, what's the approach to management?
Management really needs a team. It's a multidisciplinary approach. You'll likely involve endocrinologists for the hormone side of things,
Okay.
urologists, especially regarding fertility aspects, geneticists or genetic counselors to explain the condition and inheritance patterns, even though it's usually spontaneous. Psychologists can be really important, too, for emotional support, dealing with body image issues or learning difficulties.
So a whole team.
Yeah, and ongoing monitoring for general health is key because of those associated risks we talked about, osteoporosis, diabetes risk, etc. You might also need physiotherapists, speech therapists, depending on the individual's needs.
And what's the main medical treatment?
The cornerstone is usually testosterone replacement therapy, TRT.
Right, to replace the low levels.
Exactly. The goal is to correct that hormonal imbalance, which helps with many symptoms and can reduce some complications. Ideally, you'd start it around the time of puberty to help promote normal male development, muscle mass, body hair, voice deepening.
But it can help later, too.
Oh, definitely. Starting TRT even in adulthood is beneficial. Improves energy, mood, libido, muscle strength, bone density. It's typically given as regular injections, though gels and patches exist too.
Does it fix everything, like the breast cancer risk?
It helps tremendously with quality of life and many physical aspects, but it doesn't completely eliminate that slightly increased breast cancer risk. And currently, there isn't a standard routine screening program just for that in men with Klinefelters, but awareness is important.
Okay. What about fertility? Can treatment help there?
For men wanting to have biological children, techniques like ICSI, intracytoplasmic sperm injection, combined with testicular sperm extraction, have shown success. They can sometimes find viable sperm even if the count is very low.
So there are options.
There are options, yes. Another route some choose is artificial insemination by donor or aid. And for the gynaecomastia, if it's causing significant distress, plastic surgery is an option to reduce the breast tissue.
Okay, so that mnemonic you mentioned earlier, MLTIT.
Yeah, that's a
Huh,
good way to remember it. Multi-eye disciplinary approach and testosterone therapy hits the main points of management.
perfect. So overall, what's the general outlook, the prognosis for someone with Klinefelters?
Generally, the prognosis is actually quite good, especially with early diagnosis and proper management.
That's good to hear.
Yeah, with the right support network and treatments like testosterone therapy, individuals can lead healthy, normal, fulfilling lives. The main ongoing things are usually managing the fertility aspect, keeping hormone levels balanced, and addressing any learning or psychosocial challenges if they arise.
Okay. And just to recap the potential problems if it isn't managed well, the complications.
Right, so the core issue is often infertility. But beyond that, it's about managing those increased risks we listed earlier. Definitely osteoporosis, diabetes, the slightly higher risk of breast cancer.
The extra association.
Exactly. And without support, psychosocial challenges or learning difficulties can become more significant hurdles. So that regular follow-up, the monitoring, the multidisciplinary input, it's all crucial for good long-term health and minimizing complications.
This has been incredibly helpful, a really clear run through. It definitely highlights that, while having that extra chromosome brings specific challenges, getting diagnosed early and getting the right support makes a huge difference.
Absolutely.
It really makes you think about that delicate balance in our genetics, doesn't it? How interconnected everything is, genes, hormones, development, long-term health. What does that tell us about how complex we really are?
It tells us we're incredibly complex, and that understanding these connections is vital for providing effective care. It underscores the need for ongoing research and comprehensive individualized support for people living with genetic variations like Klinefelters.
Well, hopefully this deep dive has given you, our listener, a really clear, high-yield overview of Klinefelter syndrome, perfect for your revision or just general understanding.
We hope so.
And if you are revising for the MSRA and want more in-depth materials, practice questions, all that good stuff, definitely head over to passmsra.com.
And don't forget, there are some great free resources available too at freemsoap.com, worth checking out.
Absolutely. Thanks so much for tuning in to the deep dive for this important discussion.